On this episode of the Ask Mike Reinold Show, we talk about how we use blood flow restriction training with our post-operative knee patients.
The Ask Mike Reinold Show. Helping people feel better, move better, and perform better.
Before we get to the podcast, I wanted to make sure you knew about my free online course on the Introduction to Performance Therapy and Training. If you want to learn how to get started optimizing and enhancing performance, this is the course for you. Head to mikereinold.com/performance to sign up today. Welcome back, everybody, to the latest episode of the Ask Mike Reinold Show. I am up at Champion PT and Performance up in Boston, Massachusetts. Should we stop saying that, by the way, since half of us aren't at Champion when we do these, right?
Somewhere around Champion's greater area.
We're around the greater Boston area. You know what? Of all those things that we're going to come out better from this pandemic and we're going to actually be better for it, like birthday parades. I think that's my favorite thing so far, birthday parades. But I think doing this podcast via Zoom might, this is sticking, right? We're never going to get back together, right?
I'm a big in-person fan. I like the dynamic when we're all in the room, but I think Zoom has its advantages as well.
Well, we'd have to get stadium seating just to even record it now. But anyway, we are here answering your questions as always. If you have a question, you can submit it to us as well. Head to mikereinold.com, click on that podcast link, and there's a form to fill out so we can answer your questions. So let's see. I'm joined today. We got Dave Tilley, Kevin Coughlin, Lenny Macrina, Mike Scaduto, Lisa Lowe. Lisa Lowe with her married name. That's gonna get old. We got to just make that adjustment. Lisa Lowe, Dan Pope, Dewesh Podell, all here for you answering your questions. Len, who do we have for students today? I think we got some new students to introduce, right?
Crap, I don't have my cheat list. We have Eric Deutsch from the New York Institute of Technology. I think that's where he goes. Who do we else? We have Brian Hunter somewhere in there. I don't even see them because that's not what my screen is showing me. So I'm going off memory. He just started recently. He's from the University of Hartford. I think he comes in every day wearing a Cincinnati Red shirt because he played minor league baseball there. Just kind of remind us. And who else do we have? Is Morgan still with us? So we have Eric. We have Brian. I honestly can't see them, so I have no idea who our current students are.
So you're a big gallery view guy with Zoom. You're not a.
I just did default. So, and Cody Adams from Franklin Pierce University in the beautiful state of Arizona, I think, but they're in New Hampshire too.
Good recovery, Len. Cody, way to be memorable. I love it. That's awesome. All right.
He showed up a little late, so I forget about him sometimes.
Well said. Step number one for a clinical rotation: don't show up a week late. Right? That's how do you have a good impression? That's the podcast episode this week. Right? Just kidding. There's some miscommunication. We're gonna blame it all on somebody else. But anyway,
yes,
Eric, what do we have for a question today?
All right, so we got using BFR after knee surgery. Tom from Maryland. I recently purchased Mike and Dan Lorenz's online course on blood flow restriction training, and I'm excited to start using BFR with my patients. I'd love to hear how you all utilize BFR in a post-operative patient. Maybe discuss a case example of a knee surgery patient and how you started using BFR and how you progressed it over their rehab.
Awesome. Good job, Eric. I like it. Yeah, you know what? I actually think that's a fairly common question. We see that a lot online, like on social media. You guys probably seen that a little bit too, is I think everybody's, blood flow restriction training is getting more popular, right? BFR is definitely more popular, but I think a lot of people lack the creativity of exactly how to apply it. And, I don't blame them. It's new. You don't want to do it wrong. You don't want to waste time. You don't want to have any safety things. So, Dan Lorenz and I that, teamed up for that course kind of talk about this a little bit all the time, is that a lot of people need a little guidance. So we have some case studies in our course and stuff like that. But I like this question from Tom here, where he's like, look, just walk me through how you would use it on somebody and we can kind of go from there. So I don't know if anybody, I know we have a few people just off the top of my head head. I know, Dan's doing it on a couple of people. Dave's doing it on a couple of you. I have a minnesectomy right now. Len's done some ACL. So why don't we each take turns and just share, like, when did you start using it? How did you start using it, and how'd that progress over time, like as like case studies? But Dave, you want to start it off?
Yeah, sure. So I think probably the most classic one that I recently had was just a soccer player ACL hamstring graft. And I think we started probably like 3 or 4 weeks. The doc was really just worried about incisions. So once the incisions closed and they felt comfortable, we were able to do it because they're worried about the pressure, obviously popping some stitches or stuff. So it was like 3 or 4 weeks after, but I saw her maybe like week 2 when she was there. So the first week was kind of more just basic education and swelling, but we were pretty fast on doing it for BFR and stim together. And I actually started her at like 60% limb occlusion pressure because I was a little nervous about, obviously she's never done it before. The response is high. She's exercising for the first time after surgery. She's doing stim with the BFR. So we started at 60% and just did all her open chain stuff. And then some of her hip manuals that we were doing like manually. So she did all of her like, leg raises, all her stuff over the side of the table and the hands on stuff with me. And that was it. That was really all we did for the first couple of days. After then we added like the weight shifting, the closed chain, mini squat she started to do with her protocol. And I would say it kind of started as the bulk of her exercise, like pretty much most of the time in treatment, she was using that. And then as we just went through the natural 4, 6, 8, week progression up to like maybe when she was in the gym, she started doing stuff in the gym around like 10 weeks or 12 weeks. I just started putting at the end of her rehab as like a burnout set. So she would just do quad. And at that point, after her hamstring graft, we were doing a lot of hamstring and quad stuff together. So it went from kind of all her exercises towards, increasing the limb occlusion pressure up to 80 when she could handle it. And then finally just doing like a burnout set of, quad, hamstring, calf stuff at the very, very end. And, yeah, she's doing really well. She's 8 months now, but she did have a couple times where she got a little lightheaded and we had to like kind of chill a little bit, but overall she crushed it and she's doing really, really well now.
Awesome. Well, so when you started that at the beginning, Dave, you just did your normal set rep scheme that you'd normally do, right? And you just essentially what you did is you took your normal, early post-operative stuff and you just added blood flow restriction to it, but you didn't change the set rep scheme. Is that accurate?
Yeah, because in my mind, and I mean, obviously I like to hear everyone's opinion, but I feel like there's a lot to get to early on. There's so much stuff to do in an hour between manual stuff, range of motion, swelling, soft tissue, all the exercise. Like there's so much stuff I want to get to biking that I'd rather kind of just have it on there as like a low level stimulus than being, all right, we're on 3x30 for every single quad set, leg raise. Like that's going to be a lot. And I think like it easily gets to like 20 minutes of limb occlusion pressure that you don't want to go over. So I was just cautious about that.
Yeah, I like that. And then as she progressed, like you said, you started doing it more towards the end, but then you were focusing on fatigue at the end. I like that. Awesome. All right. Who else wants to share how they used it as like a case with somebody? I know a lot of people have been doing it. Who wants to go next? Dan?
Sure. Yeah, I agree largely with Tilly. I think one of the big question marks in my head is when is it okay to start, I think it kind of comes down to a couple different things. One, we're kind of scared about circulation, clots, that type of thing. And I think for the majority of folks, we don't really know when it's safe to start. I think making sure the wound is healing appropriately is important. And a lot of docs maybe don't want you to start BFR until someone's actually ambulating, which is going to be pretty tough for, let's say, like a post-op meniscus repair when someone's non-weight bearing for a period of time. So I don't have a great answer for you, but I would say you want to start BFR as soon as possible. The only caveat I'll say, and I've made this mistake in the past, is that BFR is tough, and you're taking someone that really hasn't exercised much for a period of time. They're probably painful before the surgery, and they're deconditioned from the surgery. And then if you ask them to do sets to failure in the beginning, you really may hurt them. So you have to be a little careful. What I'd like to do is I'll actually start people in the exercise I want to do BFR on eventually, and I'll slowly ramp up the repetitions. And if they're tolerating that well, then I throw the BFR on. But that being said, I think you're fighting this battle of, all right, we want to protect the surgical site, but the longer we wait to load this area, the weaker they're going to be long-term, the harder it's going to be to get back the atrophy or the muscle mass they lost. So I would say you want to start as soon as you can, but once you start applying it, start easy and make sure they're responding well. They're not getting a lot of swelling, not getting more painful. The range of motion is still progressing well. That being said, I'm going to piggyback on Tilly. I think a lot of PTs I hear tend to make this mistake is that BFR is great for low-level stress to the body, which is phenomenal in the early stages of rehab. These folks are not going to be able to tolerate a lot of stress in general because we want to protect the surgical site, but if we do too much, we're just going to piss the area off and then set ourselves back. So it's phenomenal early stage. But once someone's able to load, I try to make that transition over to loading as soon as we're able to, because again, we want to get back to a sport specific activity and we need to protect the surgical site. But the other part is that we want to get started as soon as we can without irritating that area. So BFR ends up becoming an adjunct eventually. So when someone's able to tolerate more squatting, lunging, deadlifting, those type of things, I actually want to try to load those things without BFR. And then I may put some BFR at the end of the program. And I have a patient right now, post-op meniscus repair. She's a power lifter, and she has fallen in love with BFR training, and she does it twice a week still on top of all of other training. She loves it. She's doing really well, and she's PR in her squat and everything, and she attributes a lot of that to BFR. But I think the large majority of her success comes from her training first, and the BFR is just a little small adjunct at that point, you know?
Right. Yeah. Well said there, Dan. I think that's great. And, to your point on the safety, I mean, I think we still pretty much recommend like wait a couple of weeks for the incisions to calm down, to swelling to calm down. The research out shows the safety. It's there, it is safe, there aren't correlations with clots and stuff like that. So the safety's there. But what I really like that you've both kind of said, Dave said he starts with 60% limb occlusion pressure, for example, for the lower body, which is kind of in the medium range, right? Certainly not at the high end. And Dan kind of said something similar where we kind of like ease into it, right? I see a lot of people make the mistake where let's just say it's an early post-op. Let's say it's a patellar tendon graft ACL, and they go to a BFR course and they say that, well, I'm supposed to do 4 sets of 30 reps, 15, 15, 15 reps. That's the protocol, right? And they're doing that week 2 with knee extension after a patellar tendon graft ACL, right? And that's like 75 reps, like with not necessarily a heavy load, but when you add the limb occlusion pressure, that increases the fatigue, and that increases essentially the perceived load, to the tissue, right? So we see a lot of people just, blindly applying it like that. So I love what you guys both said is ease into it, right? It's an adjunct, and it's something that you want to slowly apply. I think that's kind of fantastic. And make sure you're doing regular load too, right? Like, Dewesh and I, we talk about this all the time when we talk about our training programs in the gym, but we like to train all like qualities of athleticism, right? So let's say strength and power, for example. I think it's the same thing with load here. Like you can argue that BFR is one type of stimulus, but we also need to do heavy load for tissue, right, with lower set rep schemes as well. And if you do them both in one session, you could argue you're working on 2 sets of qualities at once in for both strength gains as well as tissue capacity loading. So I think that's kind of neat too. So anyone else want to share their experience? I do have one too, but I want to just make sure anybody has anything different to add, or is that pretty similar?
I was just curious if anybody has an opinion on diminishing returns, meaning like, do you ever just pull it out because they're 8 months out of an ACL, 10 months out of an ACL, 18 months out of an ACL, and you're like, I'd rather just have them do 5 sets of 5 deadlifts, squats, and what am I doing? 20 pound knee extensions with BFR. Is there ever a time where it's like just not worth it anymore? You know what I mean?
That's exactly what I did with a patient that I was talking about. Up until 6 months, we were doing like burnout sets, and then at 6 months, I was like, we have so much stuff we have to do with like cutting ability speed. Like it was impossible to fit it all in an hour. She was even there. Honestly, she was there for like an hour and 45 minutes. I'm like, we can't do it anymore. And she was dead. She was crushed after her whole
right. Yeah. So like, I mean, I can see that is they're just so fatigued from everything else. Like you're just like adding this new, like they just got nothing left in the tank. I can see that. I just didn't know if there was a point where it's just like, we're just doing it to get that stimulus, and do we have enough weight on them? Do we have too much weight on them? Are they hurting, diminishing other things, other abilities to do during the session? And I don't know. I'm always trying to figure that out in my patients that I use on, like my ACLs and other things, But yeah. I mean, we may not know. I was just curious if anybody had a.
Well, it makes sense to me. Like if you go by what Dan just kind of said, and you're doing, if you are still using it in later phases, you are still doing some heavy load without occlusion and some of this together. Right. I think it comes down to like, in addition, obviously, to do you have enough time? Is it the most important thing to use in your time? Maybe it just comes down to, do they still have strength deficits? Are they still behind? And once they're not behind, then you just transition to a normal training program, right?
Right. I don't know if I'd rather do 90-pound knee extensions versus 20 pounds to 4 sets of fatigue versus just really overload if I'm doing a knee extension, for example, after an ACL. I'm always torn
I
Because we
love
don't have 90 pounds of knee extension. So
do you have a 90-pound ankle weight? That's pretty good.
Exactly.
You just started a Twitter firestorm right there. I love that. But so I just shared briefly kind of like my experience too. Very similar to Dave and Dan, but there's, as we go through this, like we learn a lot, right? So I have a great patient right now that is he tells us his symptoms quite well. I'll leave it at that. We'll just leave it at that. But like in a good way, like in somebody that, is articulate about how they're feeling all the time, a little bit more on the cautious side, but in a good way. Right. So post-op meniscectomy, we started about 2 weeks. We started using it just like Dave with neuromuscular stim during his table exercises, no change in the set rep scheme, just as it was progressing. That was kind of the first thing we did. Then remember, it's a meniscectomy, right? It's not like a patellar tendon graft or something. So pretty quickly after that, once his volitional or voluntary like control of his quad was pretty good, I had him start doing knee extensions with it. And then we started using knee extensions with more of a fatigue type protocol, like a 30-15-15-15 protocol. But I didn't start that way, right? Because I wanted to make sure we had volitional quad control first. And once we had that, we started adding that to the program to kind of get some strength gains. So a couple of things that we've done with him over time, which we kind of found out, is we started doing some like isometric mid-thigh pulls on our force plates. And we started doing that like towards like the middle like portion of his program. If we did the BFR prior to that, his ability to perform the isometric mid-thigh pulls on the force plate was down to probably about 20, 30, sometimes even 40%. Like Mike and I saw that with this particular person. His ability to produce force on the force plates was so down because he was so tired. So I actually found that I think we were tiring him out. Mike said the same thing, kind of made the same pivot in the program. We were tiring him out too early in the program. So we shifted the BFR towards after everything. Sometimes people get completely fatigued one exercise, sometimes they don't. So, we put it towards the end and he's kind of doing more of a normal program now. But then at the end, like Dave, he's doing that kind of fatigue protocol. Then he'll ride the bike with it. We're keeping it under 20 minutes. He's still getting a little bit of the benefits of that. But we thought that was really interesting. The other thing that a lot of people have said, but this particular person talks about this too, is when he does it with the neuromuscular stim, he's way more tired at the end than when he does it without the neuromuscular stim. So keep that in mind too. BFR plus neuromuscular stim in these early phases, it's not just for volitional control, but it helps get more of the muscle to contract perhaps. And if he's more tired, it's definitely getting more of like a physiological response. So kind of keep that in mind as well. So, those are good few examples. I think that's great. I mean, I think this is an important episode for people just, getting started with BFR, is that you don't just blindly follow a protocol. You have to use some common sense. And BFR is just something we can just add, right? You can just add to kind of just like supplement what you're currently doing. You don't necessarily have to change your set rep schemes or what you're doing or the exercise selection. You can just make it part of your process. Then as the person evolves, you can kind of pick and choose when to use it, maybe when to scale back and do some heavy load stuff too. But I think what we're trying to get across here is that it's a supplement. There's lots of ways to apply it. And I think if we use our brains with a little experience through this, it's going to be much more successful, right? Every time there's something new in your hands in your clinic, everybody tries to use it the same way on a lot of different people. And then you find, areas that it works well, areas that maybe it doesn't, and how you refine it. I think that was a little bit of our evolution of how we refined it. So hopefully that helps you as well. So awesome. So great episode. Thanks guys for the answers. That was a good case. Tom, that was a good question. I appreciate that. Again, if you have a question like that, head to mikereinold.com, click on that podcast link. You fill out the form to ask us questions, and please go to Apple Podcasts, Spotify, rate, review, subscribe, and we'll see you on the next episode. Thanks so much.